I now have the very unenviable task of actually talking about the evidence base for surgery or radiotherapy. And the first thing I would say is please don't shoot the messenger, because depending on who I speak to on this topic, either the urologists don't like it or the oncologists don't like it. And what I'm going to try to do is to really try and do as objectively as I can, look at the evidence for either one or the other. And of course, ultimately, we all know we need a trial in this area. So just to start off with the basics, obviously we all know what low-risk prostate cancer is, or at least we are told what low-risk prostate cancer, intermediate and high-risk prostate cancer is. These are the NICE guidelines on which our current management is based. The new NICE guidelines have this coming out, and basically high-risk localized prostate cancer, offer radical prostatectomy or radiotherapy, or high-dose rate brachytherapy and EBRT. I won't be talking much about high-dose rate brachytherapy and EBRT, except that my understanding is the outcomes seem to be pretty similar to the radiotherapy with hormones at the moment. But the NICE criteria are not the only criteria out there. And in fact, there are actually a number of these stratification systems, but broadly falling in the same categories. The NCCN criteria are more interesting because they actually sub-stratify, and they talk about a not very high risk and a very high risk category, which to my mind is either less worrying or more worrying depending on where you sit on. So what is the prevalence of high-risk prostate cancer? Well, it's not inconsiderable. In fact, it's pretty significant. The American data sets like CAPTURE and SEER, you can see that up to 26% of men will have high-risk disease who get all sorts of treatments. This large study by Abdullah, 404,000 men, 30 to 33% high-risk disease, though interestingly, he didn't actually include T3 in that particular study. If we look at the treatment cohorts, so the surgical cohorts and the radiotherapy cohorts, well, in general, we find that the radiotherapy series and surgical series in the States and the UK talk about 17%, 10 to 13%, 17 to 19% of men getting surgery or radiotherapy with high-risk disease at the outset. We looked at some of the data in our own center because I was particularly interested in the risk profiles of what we see through our PDC clinics. So this study we did across 2 centers in East Anglia, and the bottom line is that when we classified the localized cancers, we actually found that 39% of all the men who presented to us had high-risk disease, and in the so-called screening or younger age group, 22% of men would be classified as high-risk disease, so 1 in 5. We then went on to look at the East Anglia data in general over 10 years to try to identify whether or not those patterns had actually changed, gotten better, gotten worse. And in fact, while we found incidence of cancers rising and metastatic rates proportionally falling down, we actually found that the incidence of so-called intermediate and high-risk cancers were actually rising, and intermediate in particular quite exponentially. And paradoxically, the low-risk cancers were starting to bottom out. And in fact, this was a statistically significant drop. But what you can see is that high-risk cancer continues to be a very significant proportion. And if you consider the increasing incidence of prostate cancer, there's going to be an increasing burden that we're all going to have to treat. If all of these guys are going to go into active surveillance, all of these guys are going to gain radical treatment. If you look at the age distribution, perhaps not surprising, but rather interesting, is that high-risk cancer is more prevalent the older you get. Now, that's probably intuitive. But even amongst the younger cohort of men, 50 to 59 actually, then the rate is actually going up year on year. And it's this group of men and the 60 to 65s which are particularly interesting in terms of which treatment you should offer. Now, of course, the basics are that we know that high-risk localized prostate cancer is the one that's going to get you. We are all aware of the Albertson data from many years ago, and this is actually data published this year from Sweden. And they looked, very interestingly, at the long-term outcomes in non-curatively treated men in 76,000 patients. And they produced these graphs, which we are all familiar looking at. But the bottom line is, once you get to metastatic disease, then clearly your risk of dying of prostate cancer is very large. But once you look at localized prostate cancer, this is all ages. This is 65 or less, 65 to 75, and greater than 75. These orange bits become particularly relevant in this particular age group here, in the younger men, and for the high-risk group, continue to be relevant up till the age over 75 group. So if you don't treat prostate cancer, or rather non-curatively treat them, your chance of dying of prostate cancer is clearly going to be in the high-risk cohorts, and much less so in the other groups. So this is data that we have all seen before, but certainly contemporary data showing that these trends are still true. Now, what about which treatment you should give, which is really what it's all about? Well, this is a statement from the US Department of Health and Human Services in 2008. Well, no one therapy can be considered preferred. So I don't know about a gold standard yet, but that's what the Americans are saying, and we love to follow the American statements. But they do recognize that men with high-grade prostate cancer had a high probability of dying. We know this. And based on limited non-randomized trial data, disease-specific survival appeared to be comparable. Now, of course, their definition of risk was a PSA of greater than 10. And of course, there are nuances to this. So what is the evidence? Well, we've already heard about external beam radiotherapy, and I won't talk too much about it. The outcomes are actually, unfortunately for urologists, they're actually quite good. And we have to be honest about this. The cancer-specific survivals are in the 80s to 90%, depending on which studies you look at. Early study by D'Amico looking at progression-free survival at 5 years of 82%. The Whitmark study we heard about earlier on, 10-year cancer-specific survival of 88%. Bola study, high-grade T3, T4, 10-year cancer-specific survival of 89%, and really replicated in a number of different studies. We also know now that neoadjuvant hormones plus adjuvant hormones adds benefit, and radiotherapy for high-risk disease is, by definition, with hormone therapy. So, in many ways, prostatectomy is the contender to this. So the question really is, what is happening with prostatectomy in high-risk localized cancer? Well, data from the Southwest Observatory, which I was able to get a few years ago, showed that we are doing more prostatectomies for men with high-risk prostate cancer year on year. So certainly, that trend is in the UK and is happening. And what are the survival rates? Well, again, they're actually pretty good. None of this is randomized data, and this is surgical series. If you look at the data from Spahn et al. From the MPACT study, 78 months, overall survival of 82%. A study by Kuparis of 299 men, they actually had a 99% disease-specific survival at 4.7 years. Michael Zalewski is actually a clinical oncologist and published this paper, which would suggest that surgery was better than radiotherapy in terms of cancer-specific survival and metastasis-free survival. And so it goes on, really, that we can certainly demonstrate that surgery does have good outcomes from surgery for high-risk men. But the devil is in the detail. And the MPACT study did some very interesting things on well-annotated high-risk prostate cancers. So again, from that Spahn study, they actually asked the question, what happens if you have more than one high-risk factor? And they were able to show quite nicely that in the presence of more than one high-risk factor, and certainly the more high-risk factors you added on, your outcomes started to get worse. So high-risk prostate cancer, although we all know the definitions, is actually a pretty heterogeneous beast. And once you start adding in other factors, it actually has an impact on survival. This is a paper by Briganti last year, again looking at the MPACT cohort of 3,800 men. And what they did was ask the very practical questions that we are faced when talking to men. What's the influence of comorbidity on the outcomes? What is the influence of age on outcomes? What is the influence of these number of risk factors on outcomes? And again, orange is death from prostate cancer, and blue is death from other or all causes. And here you can see that if you look at comorbidity scores, then if you have a Charlson comorbidity score index of 0, so really quite fit, then prostatectomy does convey a survival benefit, and that goes up to about 60 to 64. But if you start to get a comorbidity, then that competing risk starts to get much less clear. And clearly, the older you get, the benefit of a prostatectomy starts to diminish significantly. You then overlay the number of risk factors into this, and you get this set of graphs down here. And again, Charlson score indexes of 1 or very fit men, age less than 59, 60 to 69, age greater than 70. And quite clearly, if you were saying to yourself, am I going to provide a cancer-specific mortality benefit to a patient with high-risk disease, you're talking about the men here and here. So number of risk factors becomes better. But clearly, once you get even above the age of 60 to 69, then the benefits become actually pretty mixed. Now, of course, age is just a surrogate for life expectancy. And it may well be that this should actually be life expectancy rather than absolute age. But these kind of data, I think, needs to be something we consider when counseling men regarding the benefits of surgery. Now, I'm not aware of radiotherapy data which has looked at stratification of this nature. Now, if it's out there, it would be great to look at. But I don't think that's been done. And one thing we are very good at in surgical cohorts is actually assessing these risk-competing factors. What about adjuvant radiotherapy? Well, we all do it. Radical study is one of the most high-profile, high-recruiting study in the UK. It's doing quite well, and really is going to address the question of timing and intervention of radiotherapy. But we already have a lot of data on this, that adjuvant radiotherapy improves biochemical relapse rates, not overall survival or cancer-specific survival. That data has still yet to be proven. But it certainly makes us all feel better and makes the patient feel a lot better because the PSA start to go down or don't start to rise. So what about the direct comparisons then? What is the outcomes if you were to compare surgery or radiotherapy? Well, we all know there's no good level 1 evidence. Well, actually, there is one trial from Japan which recruited about 90 patients and compared surgery and radiotherapy. And they found no particular significant difference, though a trend for benefit from surgery, but clearly underpowered and outdated radiotherapy protocols. So what you're left with is large database outputs. And so you can start off with studies which don't stratify initially by risk group. Study by Kopelian in 2002, 8-year biochemical recurrence-free survival, pretty much identical. Cooperberg's study of 2008, cancer-specific mortality, seemed to demonstrate that surgery was beneficial over radiotherapy, particularly in the context of intermediate and high-risk prostate cancer, with a relative survival of 2. And then again, these large studies from Abdullah, again suggesting that there was some benefit in surgery over radiotherapy. But one of the interesting things when you look at these series is that they do exclude a number of patients, particularly this study excluded any tumors over greater than T2C. So these are basically Gleason 8 to 10s when you look at the high-risk groups. The Zalewski study again, 8 years progression-free survival, again most apparent high-risk disease. And Hoffman et al. Published data from the prostate cancer outcome study, which I'll tell you a bit more about later, suggesting that within these cohorts, when you propensity score match them, then there was an overall and disease-specific benefit to surgery. But again, they did not include any cases above T2C. This study was one which focused actually on high-risk prostate cancer and came out a couple of years ago, Stephen Bourgian. And here, they compared radiotherapy and surgery in a fairly large cohort, and 50% of the men who had radiotherapy received ADT. And here, the 10-year cancer-specific survivals were actually identical. So when we look at the evidence base, it depends a little bit on who's publishing the data and which cohorts they select. And trying to decipher actually what is the comparable outcomes can actually be difficult to do. So what about the functional outcomes? Because above all things, what our men are concerned about is first the cancer, and after the cancer has been treated, my urinary incontinence, my sexual function. So what is the evidence for relative benefit of one against the other? I have a number of colleagues who feel that they can counsel patients about radiotherapy as well as an oncologist can, and actually quote them rates of what trouble you're going to get with radiotherapy, what trouble you can get with erectile function. Now, this is a study from the 90s and recruited in 94 and 95. We saw a little bit about this yesterday in Hash's study, Hash's presentation. And this looked at urinary, sexual, and bowel function in men who had either surgery or radiotherapy and followed up for 15 years. Now, admittedly, this is open surgery, of course. This is not robotics with all the high definition and impact on better functional outcomes, so we believe. But it is comparable. And at that time, radiotherapy, if I'm not mistaken, would probably be non-IMRT, non-conformal, and pretty broad-based. So let's concentrate just on this data here, which is those who had documented normal urinary function. And you can see that certainly both surgery and radiotherapy had an impact on urinary function. But the impact from prostatectomy was significantly worse. Now, none of these patients returned to baseline. So this is something which we need to acknowledge as well. They do not go back to baseline. And the impact of the surgical function loss is sustained and much worse in radiotherapy throughout much of the time course. Though interestingly, at 15 years and probably a bit earlier, they start to become similar. So within the first 1 to 5 years, urinary function is clearly going to be worse from surgery. What about erectile function? Again, they tracked these patients over time. And you can see here on this where there was normal or higher sexual function, both radiotherapy and surgery had significant detrimental effects on sexual function, but surgery had a much more detrimental effect, at least in the first 24 months. And then eventually, the two curves start to join together. So it does not seem to be the case that these go down and go up again. They actually go down, stay down, and then keep on going down later on. Now, whether this is replicated in the current era, we will have to see. Bowel function, of course, is the one thing which, as prostatectomy, we pride ourselves as saying we don't cause bowel trouble, radiotherapy causes bowel trouble. Now, quite clearly, that is the case in the sense that radiotherapy is more likely than prostatectomy to cause trouble with bowel function. But if you compare the scales of complaint, as it were, or the loss in the reduction in scores, it's surprisingly much less bothersome to patients than the urinary function or the sexual function. And you can see that here. But in fact, what was quite surprising to me is that even the prostatectomy patients reported some kind of loss of or a deterioration of function of bowel. And indeed, anecdotally speaking to patients, they do say that their bowel is altered as well. Now, obviously, then you start worrying about whether you put your stitches in the wrong place or what the effect have been of other things. But actually, they do have some kind of deterioration in bowel function as well. What about more contemporary data? So this was published just this year in the BJC from the Netherlands. Small cohort, but they looked at the one-year outcomes of surgery, radiotherapy, and brachytherapy to see what the comparable quality of life effects might be. And in effect, they found, similar to what we saw before, is that surgery seemed to confer a worse quality of life outcome, at least up to 1 year. They also looked at this cohort in particular because they selected their radiotherapy patients to be more comparable to the radical prostatectomy patients. This study was a decision analysis done just this year, where what they did was a Markov model, which I don't know, I can't explain, but very sophisticated, I'm sure, and looked at cohorts from different radiotherapy and surgical studies. And they modeled the QALYs, or the quality-adjusted life advantages of one versus the other. And for men with high-risk prostate cancer, their conclusion was radiotherapy and hormones was superior to surgery and radiotherapy. However, in the younger men, tri-modality treatment with surgery, radiotherapy, and hormones actually led to superior outcomes in younger men. So the quality of life issue, I think, is one that is integral to considering the outcomes of surgery or radiotherapy. And why is it important? It's because we have to acknowledge that actually we are pretty good at treating high-risk prostate cancer in general. If you look at cancer-specific mortality rates from a number of different series, then most men don't die at 10 years from cancer. Certainly what we don't know is what their morbidity is going to be from one versus the other, and that data is not so well documented. So we asked the question, surgery or radiotherapy for high-risk prostate cancer? Well, what can we say? Well, we can say that high-risk prostate cancer is the best evidence base for competing risk-benefit from radical treatment, but we recognize that high-risk cancer is a heterogeneous disease, and that radical therapy is less likely to be efficacious if you have more than one high-risk factor at a time. We now know that the standard for radiotherapy is with long-term hormone therapy, and for surgery, it's with selective radiotherapy as required. And so far, the evidence and data seem to suggest that the benefit of surgery is most apparent for younger men with high-risk disease and few comorbidities. So what are the unknowns, the gray areas? Surgery may be more effective than radiotherapy for progression-free and prostate cancer-specific survival, but these have all been in retrospective, non-randomized controlled studies. Personally, I believe that surgery provides the best local control, but probably it may be associated with worse functional outcomes, at least in the first 1 to 5 years. And the balance for patients to answer is to address is whether that's going to be a good enough trade-off for one treatment versus the other. And of course, very little level 1 evidence to help advise patients on the best first option. So this is the patient choice and our clinical conundrum, and we basically leave the patients with it. I've got 17 minutes, Tim, thanks. I've got a timer running. We've got radical radiotherapy with neoadjuvant hormones on one end, radical prostatectomy on the other, and quality of life, clinical outcomes, risk of death, benefits of control, and of course the equipoise of how to counsel these patients. So if we ask clinicians what they will do, so this is a survey we published a couple of years ago. Certainly, if you ask urologists and oncologists regarding what they consider to be the best treatment or whether there's uncertainty, then almost all of them will agree that that's the case. If you then ask them, which is the best treatment that you consider would be optimal for patients? Well, in general, the oncologists, if you ask them whether they think the treatments are equally effective, then you get a very nice split of yes, no, and don't know. If you ask the oncologist what they think is the best treatment, they're going to say radiotherapy. If you ask the urologist, by and large, they'll say surgery. But if you ask them about the men who's 60 or younger, then you get a much more equitable comparison between them. So clearly, even though there are vested interests in terms of what they think is the best treatment, when it comes to the younger men, that certainty is not so clear. The optimal trial is a trial we're trying to get funded in the UK to do a comparison, and there are many people who say it'll never happen, and I've been told that many times. The HTA are considering a feasibility for this study, And of course, the number of objections and naysayers is pretty significant. So if we are never able to do a trial as we would like to do, the question is, how do we improve the high-risk clinical outcomes? Well, clearly, if we have better pre-therapy staging, intraoperative imaging, and could we substratify patients a little better for organ confined versus non-organ confined? And more importantly, can we use some of our great science and biomarkers to help patients select what treatment they should have? There was a very interesting talk yesterday on BRCA being able to differentiate outcomes in radiotherapy but not in surgery, and maybe that might be a way for us to select our patients. But we have to bear in mind that cancer-specific mortality may not be the outcome we look for because they are pretty good already. And it should be other things, including progression, metastasis, need for ADT, local symptoms, and maybe treatment morbidity, which are going to be the important differentiators. Thank you very much. Any questions? Tim.
Thanks, Vincent. That was a really good talk. I think the question with young patients with locally advanced prostate cancer, you've shown there lots of data showing at 10 years, that we can't tell the difference between radiotherapy and surgery. But for those patients, the really important thing now is not the first decade, it's the second decade and beyond. And that's where we really don't have the data. Because if you're 55 and you've got locally advanced prostate cancer, and you're looking at the options and they say, well, at 10 years, yeah, it's whether you have this, that, there. And he's going, well, what about the next 10 years or even the 10 years after that? And that's, I think, where we may find quite big differences, but that's where we need some more evidence.
I agree, and clearly we just do not have that data going out that far out, actually. But again, it comes down to the very interesting conundrum that actually for the younger patient, our choices are now dictated by what we think might be better for them rather than the whole spectrum of high-risk disease. And it may well be we reach a stage that we say after a certain age, then the benefits of surgery, even for high-risk cancer, is so equivocal that we wouldn't go for that.